Great. Hello, everyone. Welcome. So glad that you decided to come and hear our really inspiring talk today. I am Eileen McQuaid. I'm the Associate Provost at Westmont College. This is our Westmont Downtown series, so it's a chance for us to really highlight some of our main campus faculty and have them downtown. Today it's unusual where we have a nursing faculty who's already downtown giving the lecture today. I do want to express my thanks to the Westmont Foundation, which helps support this lecture series. We couldn't do it without them. They're great partners. So grateful that they really empower us to bring our faculty downtown and have these open and free lectures on really important topics. So thank you to the Westmont Foundation and other partners in the Office of College Advancement, like that guy in the back there. So it's my pleasure to introduce the speaker today, Dr. Stephanie Curtis, who's an associate professor in our nursing program. Dr. Curtis received all her degrees at University of Florida. I think she's kind of a fan of University of Florida. She has 2 Bachelor of Science degrees, one in nutritional science and the other in nursing. And then she went on to get her doctorate in nursing practice from the University of Florida. She is a certified and practicing nurse midwife and is the primary instructor for our obstetrics class at our accelerated BSN program. And if you don't know much about our accelerated BSN program, it's on Anna Pamu and highlights the Christian liberal arts, but in the nursing context. In addition to our obstetrics class, Dr. Curtis also teaches a variety of other classes or helps co-teach some of them, pathophysiology, pharmacology, and professional roles in nursing, which is really about leadership. A colleague of hers describes Stephanie this way, as quiet yet fierce, handling everything with grace and composure. And I didn't use a midwife when I had my daughter, but boy, if I was looking for one, those are exactly the adjectives I think I would want in one, for sure. Dr. Curtis is a much beloved professor. Actually, some of her students are here. And our 4th semester students even recently voted Dr. Curtis as their sort of keynote speaker at their pinning ceremony, which is the kind of the graduation ceremony for nursing. After taking her obstetrics class, it's actually not unusual for a lot of the students to be like, this is what I want to do, which really speaks to how inspiring and compelling an instructor and teacher Dr. Curtis is. On top of all this, I've heard that she's quite the sports fan. So you might want to, after the lecture, talk about the LA Summer Olympics coming up, or volleyball, I think is one of Dr. Curtis's favorite sports. I'm sure she would welcome that too. But today is a very important topic, the topic of maternal care deserts. Important public health issue and a really important topic that I myself am just really eager to learn more about. So thank you, Dr. Curtis, for coming to share your knowledge.
That was really nice. Eileen did her research. It's like, how do you know about that? So thank you for that introduction, and thank you to my colleagues and students for being here, and my husband in the back there, thank you. I've been looking forward to this for a couple of months now, and I'll start off by saying this is what I do and it's what I love. It's a complicated issue though. So I won't be able to give you, a comprehensive analysis of the program, or of the problem, but we'll dip our toes in for sure. So just a little bit about me. You already heard that I went to the University of Florida. That's my pinning ceremony with my study group. Then I went on to be a nurse in mother, baby, or postpartum care, and then to labor and delivery. While I was in labor and delivery, that's when I started graduate school. I actually had no intentions of stopping to be a nurse. I planned to get my bachelor's and go straight to graduate school. And then a few of my mentors, they really encouraged me, you should work kind of in that more traditional role at the bedside, and I've never regretted that decision. So I went on to get my doctorate, and then I passed my boards. That's what that happy picture is at the end. And then I got into the work of midwifery. I tried to choose one, that's a picture that doesn't show too much, right? But it definitely highlights the work. So I really love what I do. My first position, I was able to do out-of-hospital birth, which is that bottom picture on your right, where I did births in a home-like setting, not quite the hospital, but not home. And we got to do home births, or not home births, but water births there. Birth, in a queen-size bed that looks like, your own home. So that was a really neat experience. At the same time, I was able to do deliveries in the hospital as well. So now I've transitioned to a teaching role. This is, like she said, that in the summer, was it the summer? Yeah, the summer. That was the first time I've been in the lead instructor role. So it's been a new challenge, but it's been a lot of fun and really rewarding. Also, as Eileen mentioned, I still practice. I like to keep myself busy. I'm at Westmont, but I also work per diem at 2 facilities, one in Ventura and then one in Lancaster, California. So I'll talk a little bit more about the facility in Lancaster. Okay, so what is a maternity care desert? So it's small, so I'll point some things out, but this map is showing the counties in the United States that are considered maternity care deserts. So these are counties that there's virtually no obstetrics care, or very, very little. So there's no OBGYN, there's no family physician that offers obstetric care, or there's no midwives that offer care, and no facilities that offer maternity care services inpatient. So you may be looking at the map and you see California, the gray represents full access to care. So you look at that and you think, California's not doing too bad. It's mostly gray. But this last few years, there's been an acceleration in maternity ward closures. And so if something's not done, we may end up looking like some of these other counties. So 35% of US counties, a little over 1,100, are considered maternity care deserts. That affects 2.3 million women living in those counties. And then there's 4.7 million more women in other counties who have limited access. So it affects somewhere around 150,000 births, which is probably underreported, so it's probably more. And then many of these counties are in rural areas, so rural access is already bad concerning access to health care, and health outcomes in rural counties are also usually poorer than other counties, so this is only exacerbating that problem. So, like I said, one thing that wasn't in the bio is that I love Star Trek, much to my husband's chagrin. But it's a complicated issue. I'm not an economist or a healthcare administrator, a sociologist. It really will take a multidisciplinary approach to try and attack this issue, but like I said, we'll touch on a couple of the problems. So, speaking of California, very, very recently, there have been multiple hospitals that have closed, and this is one of the latest closures that happened in Hemet, California. So this is a short news story about that.
But the nurses say the hospital serves a lot of women and families from underserved communities.
If this department closes, they say patients would have to drive nearly an hour away to get care. KTLA Shelby Nelson joins us live from Hemet with more. Shelby?
Sure, Mike, in exactly 2 weeks is when the Labor and Delivery Department is slated to close on Halloween, and that's why lots of nurses were out here rallying. Some of them have plans to move to the emergency department here at this hospital. Others will be going to other hospitals in the general area, Temecula, Murrieta, but today was a last-ditch effort to keep that department open. That's why they were rallying out here today. They say it's a vital resource to pregnant women.
Do not have prenatal care, and they need a safe place to have a baby.
A safe place that these nurses say will no longer exist in Hemet.
Patients before profits.
That's why nurses from the obstetrics department at Hemet Global Medical Center rallied outside the hospital, calling to keep the maternity ward open. With only 2 weeks left, its days are numbered after hospital administrators announced the suspension of its labor and delivery department due to low volume and a shortage of physician coverage.
So I have all 4 of my children at this hospital. hospital, and I've lived here since I was in second grade.
Marie Fonseca's children are grown now, but she remembers how vital it was to have the department close to where she lives. She says had it not been nearby,
I probably would have had my kids in the car. It's not as easy to get around. A lot of people don't have cars, they can't afford them. So what's going to happen to a woman that can't afford a car and live locally? Where are they going to go to have their kids?
many patients who come in are low-income women from underserved communities who will likely have to travel about 40 minutes to get the specialized care they need. Nurses say that will hinder women from accessing that care, which can create even more high-risk pregnancies.
Temecula or Marietta is so impacted by traffic that it just takes you so long to get there.
While the hospital is directing pregnant women to the emergency department to give birth, prenatal and postpartum care will have to come from somewhere else. OB charge nurse Jenny Packham is hoping something will change by October 31st.
It's devastating. I spent my whole life here. I'm sorry. My children were born here, and I've got relatives here, and it's so hard to say, just to say goodbye to this.
And we were hoping to get some type of response today. We reached out to hospital administrators, we left messages, but no one returned our calls. Although when we were out here and when that rally was going on, we did recognize a heightened security presence. Reporting live in Hemet, I'm Shelby Nelson, KTLA 5 News.
Shelby, thank you.
So this was just last month that was going on, and the charge nurse who spoke at the end, it really does break my heart. I work with nurses in Lancaster who are working so hard to keep things afloat at their facility. And, they do their very best, and we talked about some of the reviews, and, nurses, sometimes we trauma bond. We read the reviews and we kind of laugh. But, we were looking at the reviews and we said, all of this is because of poor staffing. We don't have space. The hospital really isn't providing the kind of support that we need to be able to meet the needs of the folks who are waiting for us in triage. So, seeing her like that, that's a lot of what the nurses I work with are facing as well. So, California, there's 56 hospitals that have closed since 2012. That's 16% of the acute care hospitals that have closed their maternity care services, compared to 5% nationwide since 2012. So the rate of maternity ward closures is faster in California, the state, than it is nationwide. In 2024, 6 facilities closed. The first 2, USC Verdugo Hills and Hemet, those are planned at the time of this report. But before that, Mad River, Ridgecrest, which that's highlighted red because it's sort of in the area where I work, Scripps, Adventist, another Adventist in Ventura County, and then Santa Paula Hospital in Ventura County. So this really isn't that far from home. And then last year, there were 11 that closed their maternity care wards, 4 in LA County. One of them was Centinela, and then another was Palmdale, which is about 20 minutes from Lancaster. So this is affecting Southern California. And while these areas aren't considered maternity care deserts for different reasons, a lot of these folks are in these smaller towns where it is going to be 30 to 40 miles to get to the nearest facility, or lots of traffic, especially the LA County folks. So why are these wards closing? Specifically about rural wards, possibly low birth volume, so less than 100 per year. To give you some perspective, Community Memorial in Ventura, one of the hospitals where I have privileges, we did, I want to say 178 deliveries last month. So less than 100 per year, it really is a small amount of deliveries, and it's hard for hospitals to justify sometimes keeping their doors open. I think that was a big part of the problem in Santa Paula. Private hospital ownership. So public hospitals have incentives to actually think about and consider community needs in their staffing and the way that they prepare to care for the community. Whereas private hospitals, they don't have that same incentive and don't have to have that same motivation. It would be nice, right, if everything was, all altruism, but hospitals are businesses. And sometimes, like in the protesters, they had signs that said, "Shame on you for putting profit before patients." That's what happens sometimes. Limited local family physicians. So rural areas often depend on family physicians to provide obstetric care. That is a part of their scope of practice. But a lot of family physicians, they do their rotation during their residency, and then they don't provide obstetric services anymore. They either don't get into a position where that's required of them, or that just may not be what they're interested in. I work with medical students in Ventura. They come to deliveries with me, and it's funny how some of them, they're really excited about it. And you can tell the ones that are like, "I'm here to do my 10 and I'm gone," right? So it's, family physicians is not necessarily something that they want to do. I didn't talk much about my experience in South Dakota, but up there I worked on a Native American reservation with the Rosebud Sioux tribe. And I was amazed. The facility where I worked, we didn't have an active maternity care unit. So we had to transfer our patients. They would come into the ER and then they would call me and say, "Can we transfer her, or does she have to deliver here?" And they always hoped, "Please let us transfer her. We don't want her to deliver it in the emergency room." And when we transferred, it was typically about a 30 to 40 mile drive either way, to either Valentine, Nebraska, or another town in South Dakota. And I was shocked to find out it was family physicians providing care in those facilities. So 40 miles to get to family physician, and then to get to an OBGYN, it was about 2.5 hours to the nearest tertiary care facility, and sometimes they wouldn't accept our patients, so we'd have to go 3.5 hours to Sioux Falls. So South Dakota, I didn't talk much about it because it's a really unique kind of situation involving the Indian Health Service, but that's just an example of rural areas and how they really depend on family physicians to provide care. And then low-income counties. So often low-income counties, most of the folks are going to be insured by Medicaid or some kind of federally funded or state-funded insurance. So we'll talk a little bit about Medicaid and the reimbursement rates. But again, these things are profit and revenue driven. So in these counties where there aren't many births taking place, the costs are high, and that's an existential issue, right? Our healthcare delivery in the United States, why it's so expensive. And then, you're not getting reimbursed very much from most of the insurance providers. So that ends up leading to a lot of these hospitals closing their facilities, unfortunately. So more of the why, not just rural hospitals, but in general, these wards that are closing, costs. You really can't talk about this without talking about costs, because it's really sort of at the center of the issue. So liability insurance, it's very high in obstetrics, whether you're a physician or whether you're a certified nurse midwife. It's tiny up here, but compared to other specialties in medicine, the average rate of the annual liability premium insurance is $42,000, and the next highest is somewhere 20-ish thousand, 25 for plastic surgery, so it's twice as much. So when you're employing these physicians, you're employing nurse midwives, typically the facilities will pay for these liability insurance premiums, so that's a cost that they have to consider. In California, actually, I was surprised to see that California, compared to other states, was pretty good when it came to the cost of premiums, whereas some other states like New York can be upwards of $150,000 to $200,000 a year. More about costs, decreased reimbursement rate. So obstetrics is interesting in that it's a global code when you bill. Normally, well, not normally, but depending on the specialty, it may be more of a fee-for-service model where, you provide this service, you do this procedure, and it all kind of starts to add up. Unfortunately, we've all probably gotten those bills, right, where you see each of the services that's charged to your insurance. Some of them you just can't believe, right? With obstetrics, most states go by a global fee model. So it's kind of an all-in-one package. The prenatal care, the delivery, the postpartum care is all included in this one code. The certain things in the prenatal care, of course, are specified that are included, like ultrasounds, routine blood work. But you really don't get paid for your service until the delivery happens. So in that global model, some of the care that we provide is seen as undervalued by a lot of physicians, by the American College of Obstetrics and Gynecology. There's been other models proposed to be able to compensate providers for their time. So an example of this is, as a certified nurse midwife, when I was in Georgia, we did most of our deliveries in the birth center, but if I went to the hospital with my patient, I could be there with them for 20 hours before the delivery happened. That 20 hours is not compensated. If I caught the baby, then there's compensation. But those 20 hours, that's not considered as time that's reimbursed by insurance. So again, we would love for this to be pure altruism. I always said if we could bill for like empathy and empowerment, we'd be fine. But we don't get to bill for those things. So, in order to, for people to be able to do this, to spend all of their time being on call, providing those services, being up in the middle of the night, especially my physician colleagues, they're handling emergencies on the obstetrics ward, then they have to go to the emergency room sometimes and do emergency surgery. So in order to make that worth people's while, then there needs to be some changes with third-party payers and the payer mixes. So California, the global reimbursement typically is 52% of Medicare, compared to Georgia, that's closer to 90% of Medicare. So Medicare tends to reimburse pretty close to what is billed, so that's why they framed it that way. So 52% of what you might be reimbursed by Medicare is what you're reimbursed by Medi-Cal in the state of California. So, and you can see too the difference in the fees compared to commercial insurance, where for a vaginal delivery, $3,000 with Medi-Cal, with commercial, it's about 5 times as much. So sometimes in private practice, those providers they're not encouraged to accept those folks who are insured by Medi-Cal because they are worried about cost and reimbursement and being able to pay their employees. It makes me cringe because, I became a midwife because I wanted to care for everybody, right? Whether they were underserved, whether they're insured or not. But it's a hard fact that it does affect the way that we practice and the way that we provide care. So there's also an OBGYN shortage. They mentioned that in that video about Hemet, that they had issues with physician coverage. So some of what I mentioned about the costs is definitely a reason why. One of my clinical director in Lancaster, the way he put it was, physicians are recognizing that as soon as they leave their office, they're losing money. And the reason for that is the way that they bill for gynecologic services in outpatient, in the clinic, doing those kinds of procedures is much different than obstetric care and the time that they would spend inpatient. So that model that many of us, maybe grew up and loved, where we had the family OBGYN in the community, and he delivered my mom, and he delivered my siblings, or, she was there for my best friend's baby, that model is beginning to be seen less and less because of these issues that private practice providers are having with reimbursement and being able to keep their doors open. There's a shortage of OBGYN physicians. So they say by 2030, that's weird to say, the total amount of OBGYN physicians will be short. So we're expecting, 55,000 or more to be able to meet the demands of the country, but that there could potentially be somewhere around 47,000. Well, in actuality, right now, there's only 46,500 almost practicing. So we're actually already at this place that we think we're going to be in 6 years. We're already there. And then the workforce is aging, which is similar to nursing as well, where the workforce is retiring faster than they can be replaced. The impact of the Dobbs decision. So this actually came up several times in my research, that more and more physicians are worried about consequences of legal action against them, consulting lawyers before they make decisions. In an article from the Association of Medical Colleges, 64% of physicians believe the ruling has worsened maternal mortality, and more than half are worried about the field's ability to attract future providers. So that did come up a few times in reading about the reasons for OBGYN shortages. And then the limited number of residency positions. There are lots of physicians that are interested in OBGYN, but there just aren't enough positions for them, possibly because of these maternity ward closures. And then the impacts of reduced access. So it's good to keep in mind that childbirth is the main reason that someone would be hospitalized today. So this is so much of what we're doing in hospitals, so much of what our healthcare resources are allocated towards is this time of childbirth. And I happen to think that the way we welcome children into the world is one of the most important things that we could direct our attention toward. So when we talk about the impacts of it, these long travel times. So working in Lancaster, with Ridgecrest closing, there were people that were sort of in between, and they would tell me in triage, well, I had to choose. Did I want to drive, an hour to go to Ridgecrest, or did I want to drive, 45 minutes to come here? So with Ridgecrest closing, then there's Kern County, and I think Bakersfield was the other option they had. And for a lot of them, coming to our facility was closer. So they had no relationship at all to our facility. Sometimes they would bring copies of their prenatal records, sometimes not. And so they're coming into a place where they don't know anyone, they don't know any of their providers, and they're just trying to get somewhere safe to have their baby. So lots of people in these areas with limited access are driving long distances to get to a place to have their baby. And if you have children and you've had more than one, you know that the second one can come really fast. So it's really nerve-wracking to have to drive so far when you're in labor. Delays in prenatal care. So people sometimes are slower to get to prenatal care. That has to do with insurance sometimes too, with getting their insurance active, or just trying to find a provider in their area that accepts their insurance and participates with it. So sometimes folks, they're not starting prenatal care until they're 20 to 24 weeks. And sometimes there are issues that are not caught as early as they could have been to try and reduce the risk of poor outcomes. So that definitely plays a part. I've seen many patients in triage in Lancaster that come in with high blood pressure and it's not been addressed because they haven't been to their visits. Maybe they didn't have transportation, or they had transportation, but it's no longer working. So you see lots of that in these rural areas. Increased rates of preterm birth. There's information showing that the farther distance people have to drive, there's an increased rate of preterm birth. There's an association, but not a clear reason why that is. And then the worsening of disparities. So people sometimes ask me why I keep going to Lancaster. When I first moved here, that was the first appealing position. And even though it was an hour and a half away, it was really the only option I had. And so now that I have, 2 other jobs, one of them being 15 minutes away from my house, people ask, why do you keep going to Lancaster? And a big part of that is Lancaster is really the only facility where I get to take care of Black women on a regular basis, which is really important to me because it makes such a difference to them to see representation in a position like mine. And a lot of the folks who are insured by Medi-Cal, at least 60% of them are typically Black women or of Hispanic descent. So these disparities that we already see, where Black women and women of color are more likely to have complications or more likely to experience death or near-death outcomes in labor and delivery, that's already a disparity that we see. So then closing these wards is worsening that disparity. In LA County, many of those facilities served mostly Black and Hispanic patients. So we're already seeing that there's these wide gaps, and folks who are marginalized are becoming even more marginalized with these issues. And like it says there, 80% of the folks in LA County are insured by Medi-Cal. So my experience, the students, they will understand what that means. Maybe not if you're in cohort 6 if you're here, but 4 and 5, you know. So Grau 2 para 1, this is someone who's been pregnant twice, who's given birth once already. So this is her second baby. She's 40 weeks and 2 days, so she's 2 days over her due date. The estimated fetal weight is 4,000 kilograms, which is 8 pounds, 13 ounces. This woman I saw in triage, and she's very worried about this estimate and the weight of her baby, and she's asking to be induced. She received her prenatal care in Tehachapi, which is up that on the top left there, that dot, and where she came was on the bottom right to Lancaster, where she ended up seeing me. And I said, you know, there's rules about if your provider has privileges in the facility, they can set up, you know, an induction for you. But if they don't have privileges, if there's no sort of relationship with the hospital, this kind of memorandum of agreement or a working relationship essentially, then I can't technically schedule you to be induced. There has to be an immediate need in that moment. So she's saying, why can't you induce me? Why can't you induce me? And according to, you know, our clinical guidelines, even though the baby is measuring large, objectively, that wasn't a reason for me to induce her right then and there. At our facility, we do elective inductions or inductions without medical reason at 41 weeks, which I know to a lot of people is crazy. Like, you wait until 41 weeks? When there are some facilities that are well-staffed, well-resourced, you know, like in Ventura, at 39 weeks, you know, you want to be induced for whatever reason, you can be induced, right? So there are these lower resource hospitals with lower staffing where we really can't afford to induce people at 39 weeks. We just don't have the space and the manpower to do that. So 41 weeks is when we would have induced her. So I had to tell her, you know, I'm really sorry. You know, I can't keep you today. You know, I hope you can come back in labor before 41 weeks, but if not, you know, you can come back at 41 and, you know, we'll go ahead and induce you then, because I just couldn't set up anything formal with her. We talked recently in our professional roles class about utilitarianism and how that's used a lot in healthcare. And unfortunately, I have to look around and I see all my triage beds are full. There's people in triage who've been waiting for hours already because they need to be admitted. Their water's broken, or their amniotic fluid is low for some other reason. They've got blood pressure issues, but they're stable, so they're just waiting in triage until they can get a room. It's a common occurrence, and a big part of it is because these other facilities closed. So Palmdale, which was about 20 minutes away, closed, and then, like I said, those people in that area between us and Ridgecrest, a lot of them end up coming to us. So because of that, we will have people in the lobby waiting sometimes who need to be seen, and the nurses are just doing their very best to try and triage, bring back the most acute patients, and they're sometimes making really hard decisions. And of course, you know, myself and the physician, you know, we're trying to help, but it's tough. It's tough. They're trying to manage a lot. So unfortunately, I have to be utilitarian a lot in our care delivery. And we talked about in utilitarianism, often we ignore the individual. And it's, you know, it's tough because I see this person who really should probably be induced, right? She's never had a baby that big before, but I can't do it for her. I can't do it for her. So these are the issues that hospitals that are still remaining are dealing with when these surrounding facilities are closing their units, and it's just making access to care harder and harder for women. So what efforts are being made to try and address the issue? There are some. So innovations and models of care. I'm a part of this. So it's really new in Community Memorial of Ventura to have this hospitalist model with midwives. So midwives, if you're not familiar, certified nurse midwives, we function a lot like a nurse practitioner would, where we can prescribe and we can have inpatient privileges and we can provide services inpatient. California, I think I put number 2 there, in 2020 also authorized independent practice authority. So that means we don't have to have supervision oversight, physician oversight or physician supervision. In the hospital setting, it really doesn't work that way. And it's still trying to drum up support because people are skeptical of that kind of model. But bringing along midwives into the picture is helping a lot because we're able to split those services and we're able to, as a team, address the healthcare that's going on in labor and delivery. So a lot less deliveries and pregnancies are high risk than you might think. So midwives, our scope of practice is dealing with low risk, relatively healthy, relatively low risk patients. So those are the folks that I take care of. I may co-manage. A really good example is someone with preeclampsia. So the physician would probably make the calls about how to manage the blood pressure issues, but it's typically me that's there for the delivery unless there's other complications. So working together, we're able to expand the workforce some rather than physicians trying to bear the brunt of these burdens in these areas with limited access. Now that this program is up and running, you should see the physicians when there's no midwife working that day. They go, oh, is there a midwife working tonight? That's so good. Because they know, we complement each other, right? The folks that are truly high risk, they'll take care of them. The twins, the surgery, going to the emergency room to deal with someone who's got an ectopic pregnancy, they do that. But the labor, the delivery, the support at the bedside during labor and childbirth, midwives can take care of a lot of that. So it's nice when we can work alongside each other and support each other. So that's one way that hospitals are addressing this. And it also helps with the private practice issues as well in a hospitalist model, which is being used at Cottage. There's hospitalists there who maybe aren't necessarily local to the area, but they work for a staffing company. And so they come in and they provide obstetric services 24/7. And there's also a new midwife that works there too. So there are facilities that are trying to combat these issues with healthcare delivery. And then recently, actually just last month, I believe, a new bill was signed into law that requires a 120-day notification from facilities before they close. So previously it was 90 days, but not all facilities were following that. So there's this new bill where they have to provide notice for at least 120 days in advance. The facility that closed in Palmdale, they provided very little notice and no education to the community. So people were still showing up there thinking that their doctor would be there to deliver their baby. So this bill will hopefully, it may not stop facilities from closing, but at least, there will be notice that they have to provide and a public hearing as well, so people can let their voices be heard. And then last year, there's $300 million provided to hospitals that were near bankrupt. So those hospitals that had great financial needs, they were bailed out by the state of California last year. Pretty penny was paid. So in California, I was also reading, has a deficit. So, we may not see those changes we want to see in Medi-Cal reimbursement right away, but at least there are other efforts being made to try and address the issue. So one good thing I can say about the nurses in Hemet is that they were successful in delaying the closure of their hospital. So for the students especially, this is the power of nurses and gathering and using your voice collectively in your power, right? So the closure of this facility is delayed until January 31st. What will happen after that, we don't know. But at least they bought some more time to try and collaborate with other facilities in the area, try and make some connections between practices that maybe don't have hospital privileges so they know where to send patients in the event this hospital does close its doors. So that's all I have for you. I hope this talk, I felt a little insecure at first because a lot of people who do these talks, maybe they've written a book or something, or they've been doing research for a long time. But then I saw that the theme of this series was conversations that matter. And I would say this is a conversation that absolutely matters. And I hope that, if you've got folks in these areas with limited access, that this talk will help you as far as giving them information and just raising awareness for them, knowing where they can go, doing their research ahead of time. But thank you for listening and being here. And if you have any questions, I'll do my best to answer them. Yes.
Thank you. That was a great presentation. I'm actually a maternal fetal medicine specialist.
Very good.
You kind of glossed over it, but I think the biggest solution to this problem is certified nurse midwifery care. And I came from Washington State before we moved down here, and we had a 7-hospital system. We had a handful of OBGYNs and a lot of midwives. We were able to take care of many women. Women would drive 50 miles to come to live with us. So anybody who is deciding what kind of nurse to be, labor and delivery and midwifery is awesome.
Thank you for that. I know, I appreciate that. I try not to pat myself on the back too much, like we're the answer. But it's true. We are the answer. Yes.
I know a lot of NPs go like the family practice route. Are they able to go the OB route?
Yes, so there's a women's health nurse practitioner track, so you don't have to do the midwifery track. Some people, they want to provide prenatal care, postpartum, women's health care, annual exams and do contraception and all of that, but they don't necessarily want to do the delivery part. So you could do women's health nurse practitioner as well. And then I've heard of some family NPs that are able, just depending on their clinical setting, they might be able to do a little bit of women's health as well. The liability insurance is lower.
I know nothing about nursing stuff. Maybe this is a stupid question. I'm thinking more of my experience just having a baby and how important prenatal care felt like to me. What about telehealth? Is robots?
Yes.
Vans of nurses, can we send them around on a circuit, on the first Monday a month or something? I mean, are there some other kind of ways that we can deliver this prenatal care despite all these maternity wards closing?
Yes, that's a really good point. That's especially since the pandemic, that's been some of the effort is to expand telehealth. I don't know about in California. I know when I was in Georgia, because that's where I was for the main part of the pandemic, but there was issues with healthcare insurance payers and how they're reimbursing for those things. But I know that is a part of the effort to try and increase access to telehealth and telemedicine. And some facilities so in South Dakota, for example, we didn't have an OBGYN that was there with us, but we could get someone up on telemedicine who was actually MFM, who we can consult with in the ER if we needed them. So that is one way to both help patients and also providers who maybe are out in the sticks and need some help.
Mm-hmm. And what about that idea of the robots? I mean, let's think of Star Trek. A machine that can do a lot.
Right.
And can send all that information to someone else.
I don't know. That I'm not so sure about. But I'd be all for it, though. Any other questions? Oh, yep.
What do you suggest for students who want to go down this path? After graduation, what should be your next steps?
What should be your next steps? Is that what you said?
If you want to follow this path.
If you're wanting to get into midwifery, it's So it's hotly debated, I think, amongst nurses and midwives if you should have a period of time where you work as a nurse first. And if there wasn't such a need, I'd probably say yes, absolutely work as a nurse first. But there is a really great need, so there is more of a push for folks to go straight into midwifery school. Now, could you work part-time or per diem somewhere during those, those kind of beginning, more general classes in the beginning of your degree? Absolutely, you could. But that's a hard one. But I for one, I think it's a challenge to go straight into midwifery school without having nursing experience first. But I think it's doable. I went the route of working as a nurse first. I knew I needed that personally because I hadn't had that direct patient care experience. I needed to flex my muscles of being in emergency situations and knowing how to handle it and working with the team. So that's one thing you have to figure about yourself. And then, as a student, you can join AWON, which is the Association of Women's Health Obstetric Neonatal Nurses. As a student, you can join AWON. As a student, you can join the American College of Nurse Midwives too. So even getting into those organizations, sometimes they provide training at a discount, webinars and things like that at discount for students. So I always think that's a good idea. And then trying to shadow if you can, or even just asking a midwife who you might happen to know what their day is like, because I've had my fair share of ups and downs in this specialty. So it is not for the faint of heart, but it's so worth it, what we do. So I think that would be my advice about next steps is decide if you're going to work as a nurse first, or if you want to go straight to grad school. And try to maybe as a student get involved in some specialty organizations just to expose yourself to what's going on out there. Pass your NCLEX first.
And again, this is maybe a silly question, but where do physician assistants fit into the landscape? You said that there was an OBGYN shortage. I assume that's the MD OBGYN.
Right. MD and DO.
What's the PA landscape? This area?
That's a good question. I know not many PAs do go into women's health. I used to actually guest lecture for a PA program in Georgia, and there'd be a handful of them that loved it all, and are really interested, but then they would be discouraged because they'd say it's hard for them to sometimes get into women's health positions. So with PAs, I'm honestly not so sure with them, how many of them are actually providing services to pregnant women especially. I knew of a PA who did women's health back home in Georgia, and I know one here who does it, but she doesn't do any prenatal care.